Hey guys, Dr. Sil here, Junior Doctor from Sydney, Australia. And today I have the pleasure of interviewing Dr. Mary Langcake, Director of Trauma for St. George Hospital. The trauma services at St. George Hospital cover, a lot of New South Wales, which is a very big place in Australia, if you're not aware. Today we're going to talk a bit about her life and training as a surgical specialist. But before we begin our discussion, I just wanted to say a little bit about why we're having this discussion. And as we were saying before, I feel like a lot of the insights that junior doctors, even outsiders, and especially people like medical students, a lot of the insights we get come from serendipitous chats that we have on the ward in the hospital. And I feel like that's kind of been limited during the COVID times. And so I thought we would bring it to YouTube. So we're talking with Dr. Mary Langcake. By the way, she's not only the Director of Trauma at St. George Hospital, she's also been deployed in Afghanistan with the Royal Australian Air Force. She's also the ex-chair of the Royal Australasian College of Surgeons and as I said, my ex-boss. So thank you so much for taking the time to talk to us, Mary.
Thanks for asking me, Sil.
My pleasure. Now, I really want to talk about your life, your career, the challenges you've gone through. But before we kind of dive into that, I want to know if there was ever a patient or a case that you were involved with that made you have that aha moment, that, man, I love trauma surgery moment.
I think as you go through the career, in terms of thinking about patients that have had an effect where you have that, if you like, that light bulb moment, there are going to be many that affect you in different ways. I think with respect to trauma, it's a patient that I dealt with while I was actually deployed.
Right.
I had done some trauma at Westmead Hospital, but while I was deployed, I looked after an Afghani policeman who was shot. And he was a very sick man, and we were working in a limited environment, but we did what we could for him. And he was a proud Pashtun male, being looked after by a female surgeon and female ICU nurses and female medic, which I think he found hard. But I watched how my staff engaged him and cared for him. And it made me proud to be part of that, and also obviously managing his injuries. And I'd been involved with some quite difficult trauma cases on deployment and cases at Westmead, so that when I came back and got offered the opportunity to really, I suppose, pivot from a career pathway that was going to be pretty much purely upper GI surgery, and had the opportunity to take on trauma, I realised that it resonated with me. And that trauma's not something people necessarily embrace. It isn't, if you like, in some cases, I hesitate to use the word a sexy specialty, but my view is that trauma can interrupt someone's life in a heartbeat and change it, and that they are as deserving of good care as anybody else.
I feel like there's 2 points that I found really insightful there. The first is, it sounds like what actually made you love trauma wasn't just kind of you saving the day as much as it was the team. And that's something that's really common and a big misconception because of all the drama shows with House and whatever, making it seem like there's single doctors that change people's lives. It's all about teamwork.
Oh, and I think for me, that's the beauty of trauma, is that it really is a team. I like to say that the trauma service starts with the folk that start to care for the person at the scene of the accident, the incident. That could be the public, that could be the pre-hospital personnel, right through to people who care for them in the emergency department, doctors, nurses. Our orderlies are an important part of that as well. You can't underestimate how important it is to have those folk fetching, carrying, transporting patients, and doing it in a compassionate way. It's the radiographers, the radiologists, the staff up in theatre. It is a team sport. Yeah. And to me, that's the appeal.
I've always thought we should have like a World Cleaners Day, the kind of the workforce that's not always appreciated, but think about how many COVID cases have been prevented. So it would be really interesting to hear a bit more about your career and your kind of pathway.
So thinking about what put me on the path to medicine and subsequently surgery, from the earliest age that I can recall, I wanted to be a doctor.
Really?
So yes, when other girls of my age were talking about various careers or doing nursing, I had a clear understanding that I wanted to be a doctor. I would perform surgery on my dolls at a very, very young age. Always had a fascination.
Successfully?
They never breathed
Couple
again.
of decapitated.
But, yes, indeed. But I was very good at dressings.
Oh, that's good.
So I knew going into school that that was a pathway I wanted to take. When I was in grade 6, the world's first heart transplant was performed by Christian Barnard. And while some of my colleagues were reading things like Anne of Green Gables, I was reading the Heart Explorers and learning about heart transplantation. So it's hard for me to say why. There's nobody in my family who was in health or medicine, but it was a clear pathway. Then, as occasionally...
Did your family support this
Yes.
interest and
I
direction?
think I was quite lucky in that I had a mother who was passionately interested in my sister and I pursuing what we wanted to pursue, and my dad equally, at a time when there was still occasional thoughts that once you met a nice chap and married, that's the role that a woman took. My mum was prevented from pursuing a career, so she, I won't say drove, but supported us, as Dad did, to have careers. And I have an even younger sister now, and all three of us have double degrees and had that encouragement to undertake that. So right throughout school, I found school not easy, but I was able to achieve the grades I needed. But as often happens, life throws a spanner in the works. Oh, right. And in my final year, my matriculation year as it was then, I developed quite a bad depression. And I'm not sure if that was the pressure I put on myself or otherwise, and didn't sat the exams and didn't achieve the grades I wanted. And I hadn't thought of a plan B. So for me that was devastating. Even though I had grades sufficient to get me into a science degree, for me that didn't gel. So with some encouragement, I decided to go back and sit matric again. Now that was a challenge. I had been, one of the top of the school and those sorts of things, and going back came accompanied with some muttered comments, but I was doing much better, and then got glandular fever and missed all the exams at the end of the year, which was, again, a devastating blow. But I took up the position doing science at Flinders Uni, but I was there because
Is this in the UK or in Australia?
South Australia.
South Australia is where you...
We emigrated, so I am British. We emigrated in 1965. I had my 7th birthday on the ship. So I grew up in South Australia. And I started first year science. But I think because I was there, because I hadn't thought of anything else to do, I was treading water and not doing as well as I had liked. So I ended up taking some time away from uni.
So did you take a gap year? Was it between what we would have like a year 12 and university? That's when you had time off?
No, so I did first year uni.
Okay. And that's when you came back because of the marks?
And was, as I said, probably phoning it in, I think is a fair way of putting it, and not achieving grades that would normally have satisfied me. I started second year and the same thing was happening. By that time I'd met my ex, and I said, if I keep going like this, I'm going to end up with a really mediocre degree, and I think it's time...
And were you feeling burnt out? Like, were you working as hard as you possibly could and still not feeling like you were getting what you wanted?
I think there were a combination of things. So I had a part-time job to help fund my way through uni. I was doing about 25 hours casual work at a fast food restaurant, as well as a full-time science degree. And I think my brain was still recovering from what was at that time an undiagnosed depression. Because as a teenager, while I think it's a little different now with adolescent mental health, I think people just thought I was moody. So
it's one of the most underappreciated symptoms, I think. People just find people either grumpy or irritable, and it's actually not that. It's you've got this organic process that's making you...
And I think that was a fair comment, because study became hard, concentration became hard. Everything was an effort, and I put that down to not being good enough. So the decision to actually take a step away and consider other things was a good one. And I worked full-time actually as an assistant manager for the fast food company that I'd been working with. That taught me a number of things. It taught me about responsibility to people other than myself. Also helped me learn how to manage staff, how to be partly responsible for running a business. And I enjoyed it. But it was actually my husband at the time who said, you need to go back to uni. And I said, why do you say that? And he said, because it would be a waste if you didn't. And when I went back, I was back with a clear vision that whether I made it into medical school or not, I could bring something to a science career, and I could find something within a science career that would fulfill me and satisfy me. I went in with much better motivation, which was noted by my lecturers. My grades were better as a consequence, and I was accepted to do an honours year and then became pregnant with my son. So I took a year and then went back when he was about 5 months old, which was a challenge, as you can imagine.
I can't.
And completed honours, and then worked for 2 years as a graduate research assistant at the Royal Adelaide Hospital. And around about that time, Flinders University Medical School had started to look at bringing in lateral entry people. In other words, streaming towards the first graduate program in Australia. They brought people in with previous degrees. And so I talked to Peter about it and said, I think I'll apply for this. He said, so you should. And I interviewed with my previous honours supervisor, which was interesting. And one of the questions,
is that a good thing or a bad thing?
Well, it was interesting because one of the questions asked by one of the other interviewers was, going into honours, it would have been expected you'd get a first class honours given your grade. You got a very good second class. What do you think was the factor? And part of me wanted to go ask him, but what I said was, to be able to do a first class honours, you have to have 100% dedication. You need to be able to throw everything into it. And I started honours with a 5-month-old baby, which meant there were times I perhaps couldn't put the effort in that might have been required. I said, and with those constraints, I'm delighted with the grade I was able to get. So I was accepted into second year. I was given recognition of prior learning for first year, and started at Flinders Uni in second year med. And it was challenging. I'd not studied at that level for quite some time, but it felt like being a round peg in a round hole. It felt right. And having a little one also had its challenges.
Were there any other mothers at medical school with you?
One, and she had an older daughter. The challenge for her is her older daughter had some disabilities. I was the only one with a little one. But what I found was the younger students, many of whom were 8 or 9 years younger, if I'd had to take a day off because Andrew was unwell, would be the first to come to me the following day with a set of notes or support. And, you know, one of the best friendships that I have from that time, and she remains my best friend, was one of those students who would just come and say, I noticed you weren't here. So medical school had its challenges, but I did well, and then went into internship and was accepted into basic training. Took some time off again with a bad depression after my father died, and then finished my basic training, got my primary exam on my second attempt, and went into what was then known as advanced surgical training, and started down the pathway of general surgery.
With a view of upper gastrointestinal?
No, at the time my plan was still to do cardiac surgery because my interest had been piqued as a child, and I thought that would be where I would go. And I had done a term of cardiac surgery as a resident, but I was loving general surgery. And I was at Modbury Hospital once, sitting down with a colleague of mine who was an ENT trainee. And she said, you still intending to apply for cardiac surgery? I said, oh yeah, it's what I've always wanted to do. And she looked at me and she said, is that because you think it's the pinnacle? And I said, say what now? And she said, you think if you only climb K2, you're not good enough unless you've climbed Everest. And I looked at her and said, get out of my head.
Really?
And then thought about it and realised how happy I was doing general surgery, the diversity of various things. I'd had good mentors, and I really enjoyed it. And I think she was right, that it was a question of setting a goal that you had to pick the hardest thing to do. And back then it seemed like that was cardiac surgery. I now know that's not the case. Anything you go into has its challenges. But she read it, and thinking about that, I realised I loved general surgery, and that's why I remained in general surgery, and then moved to Sydney after I'd completed my exam, started an upper GI fellowship at Westmead Hospital.
Oh, right.
And they then asked me to stay on. I thought they meant do another fellow year, but they actually offered me a consultancy. I'd been doing transplant and upper GI at that time. And I was really...
Sorry to sound silly. So what kind of transplants is that involving?
So Westmead at that time was the only what we used to call SPK, simultaneous pancreas and kidney transplant centre. So I would be on call 24 hours a day to go and do organ retrievals and then do the recipients afterwards, as well as doing the upper GI on call. I found...
Were your shifts just never ending? Did you have a stint of, what's the longest you've spent at a hospital, I wonder?
A long time, a long time.
No numbers.
I remember a birthday where...
Your birthday?
Yes. The day before, we were contacted by Darwin Hospital to say that there was a very sad case of a woman who had a non-survivable brain injury. Not declarably brain dead. Her family were American and said that she would really, really want to be an organ donor. And that meant we were going to do what's known as donation after cardiac death, or non-beating heart donation. And they'd asked a couple of other hospitals who weren't able to coordinate it, so they spoke to us. And I had a full list on that particular day, and then a full list with another consultant the following day.
So a full list, meaning you mean like from 7 or 8 a.m.
Yes.
to 5 p.m. you have patients already booked. It's going to probably go past 5 p.m. because it always takes longer than you expect.
That's correct.
And then you get this call.
And then we get this call, and then I had a full list on the Tuesday. So we as the transplant team left for Darwin about 5 o'clock. And we got up there, set up to do the donation after cardiac death. Had to wait to go into theatre because there was a guy who'd been bitten by a crocodile. That's Darwin for you.
That's Darwin.
That's Darwin for you.
Probably a tourist.
Indeed. And then when we'd finished, it was about 2 a.m. The Darwin people had very kindly bought me a birthday cake. And we were sitting waiting while our transplant coordinator had gone to make some calls and came back and said, do you want the good news or the bad news? And we said, how about we get the bad news first? Because we've been joking, knowing our luck, we'll get one of the kidneys and have to keep working. He said, we've got one of the kidneys. Okay, fine, what's the good news? It's for one of our staff members. And there'd been a staff member at Westmead who had been very, very sick and been on the waiting list for a long time, and he had matched.
Wow.
So we flew back then via Cairns. And if I may tell a little anecdote,
yeah, of course.
Cairns had lost all of its computer power, so all the bookings and everything had gone offline.
So
Cairns
just
Airport.
the geography, so you're in Darwin, and then you've gone to top of Queensland on your way to?
Sydney.
To Sydney, okay.
Because there were no direct flights at that hour.
Gosh, yeah.
So we arrived in Cairns to discover that everything was down and all the bookings had to be redone manually. So I asked the airport manager if there was somebody that we could leave, somewhere safe we could leave the donated organs, and he said, you can leave them in my office, but don't forget them. I said, no, we probably won't. And we were then allowed to go into the Qantas Club in Darwin Airport, Cairns Airport, to freshen up a little bit. Yeah. And eventually all the flights got rebooked again, and we were walking towards the boarding gate. And bear in mind, we've got 2 Eskies with red crosses on the side. And an American chap stopped us. He had his wife and 2 small children with him. And he said, are those donated organs? And we sort of said, yes, they are. And he looked at his children and he said, kids, listen, this is important. Somebody died, they've donated their organs so that somebody else can live. And that's very important. Then he thanked us. And we were quite blown away at just how beautifully he put that. And I have to say that as we carried the eskies on board, the only comment we got from an Australian was, you don't have to bring your own 4X down to Sydney, we sell it there. So we
Not
then,
quite.
yes, we then had police cars to take us back to Westmead,
Right.
whereupon we contributed to doing the actual recipient operation. So they were a long few days, but very rewarding.
Wow. I mean, were you getting any sleep, or were you getting little naps?
Oh, I think
those couple of days?
we no, not a little doze on the plane from Cairns to Sydney, but then the adrenaline was pumped because we were met by the police to get us to Westmead, and in peak hour traffic from the airport to Westmead in just under 30 minutes.
Wow.
That's
a big diff there, yeah.
That pumped the adrenaline. So
That's probably good pre-op. Just get a little bit of
Absolutely.
It's better than a coffee. So that was when you were working as a transplant surgeon,
Yes.
and then you found your way into trauma surgery via the experience in Afghanistan, or?
Well, actually, so in terms of how I got into trauma surgery, while I was at Westmead, I became good friends with the director of trauma there, Dr Mary Langcake, and she was short-staffed, so I offered to help out, and so for a period of time, I was, if you like, the sort of acting deputy director at Westmead. And Westmead, as a major trauma centre, I was dealing with trauma both as the fellow and then also as a consultant when I was on call. So working within the department gave me some insight into how a trauma service runs, the challenges, etc., working in an interdisciplinary team. Throughout my career, I'd had an interest in the military. My mother and father grew up during World War II in the UK, so I grew up hearing stories about it. Dad was in the Air Force. He left the Air Force before we came along. And I'd always had an interest in possibly joining the military as a way to contribute, to give back. The public hospital system trained me, gave me a career that would always sustain me, and I felt that this would be a way of contributing. And the right time came in 2006 to think about going down that pathway. I'd been thinking Army because I had a colleague in Adelaide who'd been sort of pressing that idea upon me, but then I met a senior Air Force doctor and senior officer and thought that the Air Force might hold some appeal. So I signed up in 2007 and went and did my Reserve Officer Training course, which was 4 days of learning how to put the uniform on properly and to march without falling down. And
Is that harder than it seems?
Yes, it is.
Okay.
It is, particularly when the person in front of you starts to square gait and you find yourself doing the same thing. And for those of you who don't know what square gating is, normally when we walk, the opposite arm goes forward to the leg that's going back. When you square gait, the same arm and the same leg come forward go back. And it's very uncoordinated.
Is it kind of like a traffic jam that if someone at the front messes up, it just ripples back down the ranks?
And once the person in front of you square gates, you find yourself doing the same. And getting yourself out of it involves a little hop and a jump to switch legs. So I'd been back from that just on 2 weeks when I had a phone call from Health Services Wing with the RAF to say that they were planning a deployment and would I be interested. And of course I said, oh, where are we going? Well, we can't tell you that. I see. When are we going? Well, we can't tell you that. Well, you better sign me up then, haven't you?
I wish I saw that conversation. I'm in.
Yeah, that put me in. And obviously, eventually discovered that it was going to be to Afghanistan. I would actually be deploying with some folk that I knew through the college and through doing EMST. And we did a training exercise in the Netherlands because we were based with the Dutch in Tarancot. And then after some training at RAF Williamtown, we were on our way in July of 2008. So I'd barely been in the Air Force a year when that opportunity came up. And obviously, under warlike conditions, you're going to see trauma that you don't see in civilian practice. It puts pressure on. It's an austere environment. I'd barely had my uniform on 2 or 3 times before leaving, so there were those challenges. Coming from having a background of mental health, I knew that would be a challenge and thought that I had enough supports, if you like, to get through that. But it was, we dealt with some fairly major trauma. I learnt to, I guess, be a little bit like MacGyver to deal with some of the things we saw. There were some considerable challenges, from a mental health perspective. But when I look back on the experience now, I also realise what I gained, and I am able to look back on it in a more positive fashion. I did come back with PTSD, which I didn't recognise at the time, because when I came back, again, that very negative self-talk of, well, you obviously weren't good enough and probably shouldn't have been there, and those sorts of things. I lost a 7-year-old on my table while I was operating, and he'd been shot. And he arrested and wasn't able to get him back. And it's a very deeply personal thing that still affects me, even though everyone I've spoken to since said that have handled it in the same way. We didn't have the ability to sit down and speak to a colleague as much because of operational security. So you internalised a lot of it, and then you come back feeling inadequate and those sorts of things. And it took me a while to get through that, but in the interim, I was offered a position at St George, just filling in as a trauma surgeon.
Can I just ask, with coming out of a PTSD kind of episode of your life, and sometimes it sits with you the rest of your life, really,
Yes.
and depression can be an episodic thing. Like, is it just time and space that gets you personally through it? Or if someone else, like other medical professionals, are kind of going through similar things, like, is there anything that worked for you? Did you MacGyver your way out of it, kind of thing?
I think it's a good way of putting it. I think the first few times I probably did MacGyver my way out of it. As I
by
said,
distracting yourself? Or,
yes. Well,
right.
my way of distracting myself is to work harder and harder and pick up extra work and extra shifts, because my way of dealing was to try and run and keep in front of it. And the way for me to do that was to work very hard. That doesn't work, because eventually I think your psyche says to your body, right, I've not been able to stop her, so slam her into a wall for a period of time for me.
Right.
And then you find you cannot keep working, whether that's due to the fatigue, which is a big factor for me, not sleeping, the sense of self-doubt, and becoming sensitive to any sort of conversations, and eventually you just have to stop. I also think that for a long time there was a sense of shame about having depression. There's a stigma around it. It exists still. I'd like to say I think it's getting better, and I think it is. But for a long time, there was a sense that having depression meant I just wasn't tough enough. And not remembering, for instance, that members of my family had depression, and therefore I was probably a sitter to get it as well. So,
and it sounds like you had kind of perfectionistic traits. You really wanted to do the best you could, but your parents were just supportive. Did they put pressure on you to do really, really well, or were they?
It's an interesting thing. I mean, Mum was always very supportive. Dad was a very silent fellow. So if I would take in a good report card with maybe straight A's, it would be, well, that's what we expect.
Right.
And you'd go, good. That's great. Well, I'm glad I met your expectations. I wouldn't say there was pressure on per se, but there certainly was an expectation. For instance, if I played up, it would be, we expect better from you. If I got,
there was,
and that was at school as well. If I was like any other child and talked in class, rather than quiet now, it was, we expect better from you, and therefore I expected better from myself.
Okay.
So the pressure was two ways, I think.
Yeah.
And so I know that with the depression, it was, if you have depression, it means you're just not good enough. You're not tough enough, you're not strong enough. And so I would beat myself up with that. And I think it wasn't until I was actually coming towards sitting my primary, and I really had a major breakdown going into that, that I finally sought help. And I was very grateful. It was actually the head of ED at Flinders at the time, who I reached out to when I found myself being very vulnerable, and who just provided not just mentorship but friendship and support, and facilitated me recognising that this was an illness. and that I was sick.
Yeah.
I wasn't weak or useless or things like that.
You'd never say that to someone with a broken leg, right?
Of course
Like,
not.
You got to toughen up. It's
That's
a broken
right.
bone.
It's a broken bone. And so in a sense, I had a broken soul, if you like. And I won't say that, starting to get help then didn't prevent the negative self-talk. For quite some years, I would, again, try and outrun it when I could feel it coming on. And it took a long time to start to recognise that this is something I would probably live with for the rest of my life. And I had to learn to deal with it better. And I also had to learn to talk about it. I had to learn to speak to medical students and junior doctors and colleagues and anyone else to say, you know what, I have a 100% record of recovering from depression. Very few people have 100% pass rate in things. And that managed appropriately, if you had Crohn's and you wanted to be an engineer or you wanted to be a doctor, you can do that if you manage it well. If you've got diabetes, you can be a really good doctor. If you have depression and you manage it well, you can be a really good doctor. And by learning to talk about it more openly, I became more accepting of myself.
So with people who have chronic pain, for example, it's funny because sometimes we can't fix chronic pain. But if we teach acceptance therapy, I accept that this pain will be with me for the rest of my life. The people who accept it versus the people who can't get to terms with it have very different intensity of pain.
Yes.
So having that acceptance of a horrible situation, it builds that long-term management skill. And being an intern with your team, back when I was young, a couple months ago, like the mental health aspects of trauma surgery, I wasn't expecting to be so intense. But the way you spoke with patients, and sometimes the team would leave and you would stay back and be like, look, like this can play on your mind. And so I started doing that as well. I started being like, look, and I've done it just in the community as well. When the other day I was at pre-Omicron surge, I was at a party and someone had a bad motorbike accident and ripped his leg apart and was at a trauma center, not this one though. And no one had talked to him about PTSD, but I just brought it up. I was like, look, that's a serious injury. That stuff can intrude in your sleep and your thoughts. And he cried on the spot. He was so close to, he just needed to get it off his chest.
Yes.
I had never met him before, and he was just, this is a tough guy who motorbikes, right? And then the second he had this doorway open to him, he went straight for, I've been waiting for this door to open so I can talk about it.
And I mean,
so being aware of it in trauma surgery just seems so important.
That's a really good point, because I said to you when I was giving you feedback that I recognised the empathy that you showed right at the outset, and I think we all need to. I'm very mindful of the work by Brené Brown that a lot of people would know about. I was first introduced to her work by a social worker that I met the one and only time I was ever hospitalised with my depression. And she's a mental health worker trained,
right.
and I started seeing her regularly. And she asked me to read this book, and I thought, it's going to be about building a campfire, sitting around, holding hands and singing Kumbaya. And the book was called I Thought It Was Just Me, and It Isn't. And it was based on...
That's a good title for a book.
Indeed.
It's a very good title.
And Brené Brown is a clinical psychologist, and she did her postdoc on shame in women. And as I was reading this book, I kept looking around to see where the cameras were, because it seemed she'd had a camera and a microphone on my life. And she distinguishes shame from guilt, where guilt is, I've done something bad. Shame is, I am bad. And she focused initially in women, and then men said, why haven't you looked at shame in men? And she said, I didn't know that men felt the same way. And since that time, her work, she's very approachable. I've seen her talk live, she's wonderful, but her work is approachable. She's a qualitative researcher, and she's written a number of excellent books, and some of the ones that again have resonated with me are Daring Greatly. One that I was only even recommending to my son yesterday is called The Gifts of Imperfection, and I'll muck up the subtitle, but it's along the lines of how to give up being who we think we ought to be and be who we are. And she talks about...
I'm going to try and find all these books and put them in the links below in the description.
Definitely, and it's about saying, you look at other people, you think, oh my God, their life is so perfect. You don't know what's going on. And you talked about being a perfectionist. Again, Judith, who's my mental health worker, said to me once, have you ever met someone who is perfect? I said, no. have you ever been somewhere perfect? I said, well, no. She said, then why have you spent most of your life trying to go somewhere that doesn't exist and be someone that doesn't exist? And I was a little taken aback. And then I recognised what she meant.
Yeah, I feel like that's actually, so I'm interested in emergency medicine. I feel like it's a very good characteristic to have in emergency medicine, because you'll never have perfect care in emergency. And healthcare in general is a system of infinite demand and limited supply. You put $1 billion into healthcare today, tomorrow you'll need another billion to meet the new demands.
Absolutely.
And yeah, we can't ever do everything, but we just do our best, and it's pretty good on the international standard.
And I think, you make a point about, mental health and resources, but the one resource that's free and that we can always give is kindness. And I try and remind myself, even when maybe I'm frustrated with a patient or frustrated with a colleague, that if I can take that breath and as Judith says to me, respond rather than react, and think, okay, that colleague's been a bit snippy.
I like that. Respond
rather than react.
That's a good one-liner.
Yes. Maybe that colleague's had a really, really bad day today, and maybe I'm just that final person making a request. And if I snap, maybe that will be the thing that brings them down. So if I can take a deep breath and say, why don't we talk about this a bit later, or we'll just take that offline. And if I can remain kind in my interactions, and I'm not perfect, don't get me wrong, there are times that I will react rather than respond. But I think my way of wanting in my life is just to say, if I've been kind to that person, then that may be the one thing they remember. And whether that's just sitting in that moment and listening. I read a study once that said the average amount of time that a doctor listens to a patient before they interrupt is about 20 seconds.
Oh gosh, that's so true.
And surgeons are worse.
I bet, yeah, okay.
And I find
Emergency medicine doctors probably aren't great either.
Probably similar. And I find myself thinking, if a patient is talking to me now, just listen. Don't want to come in. Yes, I might be pressed for time, but it might be in that moment, like listening to your motorcycle colleague, that real moment of contact, that empathy comes out that permits that individual to talk about what's really concerning them. And so that kindness, that being in the moment, is how I try and teach people working with me as well. Because if we can remember to be kind, then I think a lot of the rest of it will follow.
Outstanding. On a bit of a separate note, it would be probably interesting for medical students or junior doctors listening to know how to become a trauma surgeon. So what is the pathway?
So first of all, you need to undertake SET training, which is surgical education and training.
So you've gone through med school,
yes.
You've done internship,
you've
done
intern
residency.
Year, and so you then, you need to be in your PGY3, postgraduate year 3, before you can apply for SET training. You can register with the Royal Australasian College of Surgeons as a pre-SET trainee. And if you do that, that gives you access to resources like a portfolio called JDocs, which gives you an idea of some of the prerequisites for various training programs and gives you access.
And is that an unaccredited registrar, this pre-SET trainee?
Yes.
Right.
So that is what we might call a pre-vocational trainee. So you can register with them fairly early, but you can't apply for SET training until the year of your postgraduate year 3 to apply for the following year.
Cool.
It's unusual for people to get in that early. Some individuals do. It's quite competitive. Once you have been accepted onto the surgical education and training program, the commonest pathway is probably through general surgery for people that want to do trauma. However, I have colleagues who are vascular surgeons.
I thought it was only through general surgery, but
no.
You can go via other
yes, you can.
training programs.
So
okay.
I have colleagues who are orthopaedic surgeons as well. And then within general surgery, you will have people that have different specialties. I've got 2 colleagues who are actually breast surgeons. In Australia, being a full-time trauma surgeon is unusual.
Right.
We perhaps don't see the volume of trauma that they do elsewhere, like South Africa and the United States. So a lot of people...
Which I guess is a good thing.
Oh, I
for society.
Totally agree. So people may undertake, perhaps like I did originally, upper GI training, but then they may be on the trauma roster within the trauma hospital in which they're working, and that's really important. It's important to have different colleagues in different specialties. In terms of, I guess, in some ways saying trauma surgeon, there are some models now where important parts of the team are in fact trauma physicians, if you like. So for a period of time we had an ED physician who worked with us as part of the service. The head of the service at the Alfred is an ED physician. So people can come to trauma from different specialties, and we've had an anaesthetist working on the service, and I think that again reflects the very collegiate and interdisciplinary nature.
I've always found trauma is like an orchestra,
Yes,
you need the violinists, you need the trumpeters, you need all these different perspectives, and really the head of trauma is a conductor that has to do thoracotomies occasionally.
Indeed, and in actual fact, the trauma team leader shouldn't be hands-on at the time of resuscitation.
That was a very interesting observation that I learnt with you. And we saw thoracotomies, people's chest being opened up. I've seen you give cardiac massage, and these horrendous, these chaotic things with 10, 20 people around patients, and sometimes you're at the head of the bed and you do this, you do that. For CT scanner, no, too unstable. You're a conductor, and you know what this leads to? I think people would be interested. So it leads well into the next question, which I'd love to know. Does anything scare you now?
In the moment, probably no, for the simple reason that you get the pre-hospital notification and you might be thinking, oh crikey, that doesn't sound good. But that's part of the planning. So a lot of people say that trauma surgeons are adrenaline junkies. That may be true, but I think and trauma physicians, I think what we have the ability to do is to listen to that pre-hospital information and go, right, that individual doesn't sound well. And then to, working with colleagues, work out how you're going to receive that patient, what you need to do, what your colleagues need to do, what the nursing staff need to do, and to have a plan. And part of that is that we rehearse those things. So we know what's expected, and that can come from doing particular courses or to working. I've worked very intensively now with most of the staff specialists in ED, and we know each other. And you get into a rhythm. And so in that rhythm, you certainly might be concerned for your patient. You might be thinking, this patient's very, very unwell. There's not a fear per se, because you know what you need to do. And I think the most important thing, and I learnt this after beating myself up about, losing that little fellow in Afghanistan, is regardless of the outcome, if I and my colleagues can debrief with each other afterwards and say, to the best of our ability, to the best of our knowledge and the best of our skills, we gave everything that we could.
That was world-class care, what that person received, yep.
They received our compassion, our skills and our knowledge. Then you can say, and you do go home, patients live with you in your head, but you can go home and say, if that individual was going to survive, they had every possible chance because we responded appropriately. So while there are certainly some things that will make me go, righto, this is going to be a challenge, within that, when you've got good people working with you, and one thing I would say to any junior doctors listening is, get a mate, get help. For instance, if I know I've got someone with a really bad liver injury, I call David Morris. David's our head of the peritoneectomy service. I trained as an upper GI hepatobiliary surgeon. But if I'm going to theatre with a bad liver, I want David there. And I will say he's always there. So the point I'm making is, don't think you have to do it by yourself. And as you come...
It's the teamwork.
It is the teamwork. And whether that's you seeing someone on the ward that worries you or being down in ED, you say, I'm going to need a hand with this. And even if that's just because it means you can bounce ideas off each other. And that's where trauma is so good, because you've got your senior ED colleague. I'll have one of my colleagues with me, or I'll be there for them. And you know that you are then working as part of that team. And that's such an important point.
Thank you, Mary. So Mary, we actually got some questions from people on the Discord server, which is how we kind of communicate. And I have two interesting, we've answered some of them already, but one of the ones I wanted to ask, actually that Naomi sent in.
Hi, Naomi.
Thanks for sending it through, Naomi. Was what have you found to be the biggest challenge, that kind of as director of trauma during the pandemic, particularly? Like, how does COVID affect trauma surgery at the moment?
I think the effect that COVID has had is on the stress that everybody's feeling. So our ED colleagues have just worked above and beyond, our ICU colleagues as well. And so in the middle of having a completely packed emergency department due to seriously ill COVID cases, to have a major trauma come in puts a challenge on. And certainly I know that my team and I want to make sure that we're responsive, that we're down there, we're sharing our part of the workload. And I am amazed at how the staff down there can suddenly step away from managing very sick COVID patients and come on and be responsive to managing trauma. There are challenges in getting a patient into intensive care.
Oh, yeah.
So we have a rib fixation program here at St George, as you will be aware. And we usually like to have those folk in the intensive care unit at least overnight. And we've had cases delayed because there simply haven't been ICU beds available. Having said that, however, it's led us to slightly modify what we do and with discussion with the nurse unit manager, actually take a couple of those slightly fitter patients back to the ward straight away, wow, which has worked well. So we've had to innovate. I think that one of the big things, the effect that it's had, and this has not just affected trauma though, is the ability for relatives to come in and see patients. That's been very hard. And it's hard for us because we recognise how stressed that families are, particularly with trauma, which, as I said, changes someone's life in an instant. And I had an elderly fellow who came in with a terrible brain bleed. This is going back just over a month or so ago. And it was apparent he was not going to survive. And trying to organise for family to be able to come and be with him as he passed. And I will say, I rang the hospital executive and pointed out the situation, and they were wonderful, and the staff on the ward were wonderful.
That's great.
But I know that that's been a challenge. So one of the things that we've brought in as a consequence is that every day or every second day now, I ensure that at the end of the ward round, the team rings relatives. We have a list of names on the board of the people and the numbers, and it might just be just updating you to let you know what's happening with John, or your mum's doing well. That's meant a lot to people, and I wonder why I hadn't thought of it before, to be perfectly frank. So I think my feeling is that the ability to practice that humanity has been affected. That sense of comfort of being able to put a hand on someone's shoulder, or give a relative a hug, or just hold someone. When you're masked up with somebody as well, I think it's difficult to convey emotions. And I think that humanity is so important in what we do. And I think that's been restricted by the pandemic.
I agree. And I find it's been really useful as an intern to do these family phone updates. I feel like a lot of doctors are worried that maybe the calls will last too long, but people are very sensible. Like, people are just grateful to be getting an update a lot of the time.
And they're mindful of your time.
Yeah, exactly.
They say, thank you, I know how busy you are.
I really appreciate the time. And then it makes you feel good as well. You're connecting to the bigger situation. I think we're going to leave it there, Mary, for the only reason that everything's running out of space. All the cameras have run out of space. But thank you so much for being so open, vulnerable, honest. You're an incredible role model and director of trauma, and I wish you all the best. I hope we can do this again. Thanks everyone for joining in. If you want to support the channel, leave the video a like, and if you've made it till now, leave a comment of a stethoscope. Then I'll know who stayed till the end.
Thank you, Sil. It's
All
been
the
a
best.
privilege.
Bye for now.